Well, it's top of the hour, so I'd like to welcome you to our PFCC Connect continuing conversation on COVID-19. Today's conversation is about PFCC and pediatric partnerships during COVID-19. I'm the facilitator of the conversation. My name is Mary Minetti, and I work as a Senior Policy and Programming Specialist with IPFCC, and I'm joined by my colleague, Deborah Dokken, who is the Coordinator for Patient and Family Partnerships. She is leading a project that is funded by a grant from the Lucille Packard Foundation for Children's Health in Palo Alto, California. And so she will be our chat monitor today. Welcome, Deborah. Thank you for joining us. And
Thank you, Mary. Welcome, everyone.
And of course, behind the scenes, Natasha Reed is our registration and database manager. And without her, we wouldn't be able to see all these things on the screen, including the quick poll that you are filling out, I hope. I appreciate that you, a number of you are choosing to be on the phone, and that happens. And a number of you are choosing not to be on the video. If you can be on the video and want to be able to see the faces of the other colleagues that care about this particular topic, we recommend that you do so. But again, it's a choice that you have. So today's conversation is the first in a series of free webinars and online conversations for children's hospitals and other pediatric settings that will be focused on PFCC during COVID-19. So this is the first conversation as part of this Lucille Packard Foundation grant. And we are really using this time to bring those of you working in children's hospitals and other pediatric centers, either as administrators or clinicians or patient and parent family advisors, to come together and really chat with us about what's important to you. We're going to use the time to identify some key issues and prioritize them. So we want to get started with that as soon as possible. Natasha, I'm wondering if we can go ahead and end this poll and see what we've got going here. So, wow, we've got 60% of the people are working as parent or family advisors. That's a significant number. 50% are coordinators. I know sometimes people wear more than one hat. Number of patient experience folks. It's always nice to see child life specialists on the call. You're an important member of the team, as well as we've got some administrative, physician, and measurement and quality folks. So we really appreciate the time that you're taking to join us today. It becomes really important to us that we bring all perspectives together to discuss what's important during this pandemic time in the pediatric settings. You want to go to the next slide, Natasha? For those of you that would like to share your name, organization, and country that you represent, we're going to get a sense of what's going on. We encourage those of you that are able to use the chat as well as to speak live during the conversation. The goal really is for us to learn from each other, and Deborah and I in particular, Deborah, are going to pay very close attention to the real rich conversation we're going to have in a moment about the priorities that you have. We are going to, of course, make all of these resources available to members of the PFCC Connect community, learning community, in the conversation folder. If you want to go ahead and go to the next slide, please. We do use polls to have an understanding of who is on the call and what's happening. And so this is our second poll that just kind of gives us an idea of what pediatric setting that you are representing, whether it's a children's hospital or an adult hospital with pediatric unit, an NICU oncology unit, and a number of those kinds of things, a pediatric care clinic. Now, what I notice about this poll is that because of the space limitations, there are additional choices if you scroll down to behavioral health, outpatient pediatric specialty programs, community programs. And so we're very interested in knowing which of these settings you might be representing. So if you want to take just a moment, what we may find in our conversation is that the issues that are important to you um, span across the settings, or they may be specific to the particular settings. So it's helpful for us to know who's not only who's on the call in terms of the conversations and the roles that you have, but also the settings that you may be working in. And you may find that you work in a variety of settings. I'm thinking maybe perhaps the child life specialist works in a variety of settings. And so you may check more than one of those particular polls. So take just a moment to do that, and we will close that poll when Natasha feels like we have good representation of the individuals that are on the call.
I'm going to give this just a few more seconds, Mary. We only have about a handful of responses so far.
Okay, great. So we'll take just a little bit more time on that.
I think that people can't submit because it's making you answer the second question, which does not apply to everyone. So what would you like us to put for that?
So what I think, and it's requiring that you make that choice. So
yes,
Natasha, I'm not sure how to deal with this. Why don't we, since probably most of you are in the other areas of the hospital or in the community settings, why don't you go ahead and choose randomly number 2? We won't really use that information. If you are in another pediatric setting that's not listed, or a non-pediatric healthcare setting, we're going to ask those of you that applies to actually type that into the chat, and we'll use that data to understand what percentage of people represent those. So we're going to basically skew the data on number 2 so that we can complete the poll. Does that make sense? Thanks for asking that question. It's a good one, and it's something we need to be mindful of. We don't normally have so many choices, so we don't often go into a number 2, and I don't know that we knew that that was going to happen. So technology is always a surprise. So again, whether or not you're in one of those settings, choose one. But if you are in fact in those settings, please type it into the chat so that we can keep track of that. How are we doing, Natasha? That may have answered the question why so many people haven't submitted.
It did, and we got a big bump. Just
Okay.
as a notice, the next poll is going to be the same way.
That is going to be okay. Well, we will be flexible about that. So it looks like we won't look at number 2, but strong majority, 86% are representing children's hospitals, 10% adult hospitals with pediatric units. Some pediatric primary care clinics are represented. That's great. We have quite a mix, quite a range, although most are representing children's hospitals. Thank you so much for responding to the poll. We want to go ahead and go to the next slide, please. So I'm going to turn this over to Deborah, who's going to take herself off mute and talk a little bit about this project that we're working on and give you some background. Deborah?
Thank you, Mary. So this new project that actually just began mirrors some of the work that IPFCC has been doing since the beginning of COVID-19, namely to be a resource and a clearinghouse for up-to-date, easily accessible information about how can we all stay grounded in patient and family-centered care during the time of the pandemic. This project differs because it has a specific focus on children's hospitals and other pediatric settings. And although we will be gathering information from you and from other sources, the real heart of this project are a series of free webinars and online conversations, starting with the one today and going through October of this calendar year. And as Mary mentioned before, we're very, very grateful that we have a grant from the Lucille Packard Foundation for Children's Health in Palo Alto, California. Mary?
Next slide,
Okay.
Natasha, please. What you see in front of you are the dates, if you want to go ahead and get them on your calendar, and you will get a copy of these slides, and we will post when these are upcoming and send registration links and those kinds of things. But we did want to let you know that we've got 2 more informal conversations, and based on the information we get today, as well as information that we're gathering ongoing, it will help inform the webinars, the first of which is going to be Thursday, June 25th at noon Eastern time, and up through and including October. So lots is going to be going on, and it's an important arena in which to have these conversations and to continue to learn from each other. Deborah, did you want to talk a little bit about what the hope with the webinars is? I think most people are familiar with the informal conversations that we have, and those are really a gathering of ideas and sharing of learning. How will the webinars differ from the informal conversations?
The webinars will differ in the sense that drawing from these informal conversations, from other things that we know from the field and pediatric settings in this time, that there will be more information, summarized information that will be provided, but we will also be spotlighting institutions, pediatric institutions that during this time have really been able to find a variety of ways to, as I said, maintain patient and family-centered care during this time. So whether it's use of telehealth, it's sharing ways that they might have called upon their advisors and their family advisory committees in different ways during this time.
Great. Thanks for clarifying that, Deborah. We can go to the next slide, Natasha, please. So we are going to do the poll now, and let's bring it up. I know it's going to be in 2 sections again, but let's see. So with this poll, we're asking something a little differently. What we're asking you to do is to review all of the poll results and check your top 3 priorities. If the 2 items that are on the bottom, number 2, longer term harms to children or others, please chat that in. If you really don't have an other, but you have to make a choice in number 2, and longer term harm isn't one of your top 3, just click other, please chat it in, and you don't need to chat anything in if you're choosing it, just so that you can get through this poll. Again, I apologize for technology. Sometimes it surprises us. But most of the priority issues that we've heard in the field to date or are listed within the primary list. And again, if you do check other and need to chat in an issue that we haven't listed, please do so. But I'm going to just take a minute. Hopefully that this isn't too confusing in terms of my my directions. But take a moment with the poll, and we will summarize it in just a minute, and that will help drive our conversation after that. And Lauren, thanks for chatting in another that we hadn't thought about. So thanks for doing that. And Natasha, I'm going to rely on you to let us know when you feel like out of the 43 people we have that are participating that we have a reasonable response to the poll.
Okay, I'm gonna give this just a few more seconds. We're almost at 60%.
Great. Okay, we're going to keep that up for a minute to really take a close look at it. Okay, we've got it looks like the top three in terms of percentages, we've got current impact on vulnerable populations, rates high, family presence policies, which is an issue, current involvement of patient and family advisors, policy and practice. This is going to kind of drive our conversation because I'm going to want to hear more from people, and long-term harms to kids. So those are the ones that are in the 40 to 50 range, unless I've missed some. So Natasha, if you can go to the next poll, or not the next poll, but the next slide. Thanks so much. So what we want to do now is really open up the conversation so that we can really help. We've got a sense of what came up on people's radar in terms of the things that you identified as your top three priorities. And so what I want to do is really open it up and ask people to help us understand your choices. So let's talk a little bit about current impact on vulnerable populations. If you checked that as one of your top three, I'm hoping that you'll take yourself off mute and just help us understand and give some context to why that rose to the surface for you in this particular time period during the pandemic. So I've got a lot of people on mute. So you're going to have to take yourself off mute so that you can share. Who'd like to share about what you're thinking about issues?
Mary, this
Yeah.
is Angela Miney at the University of Florida Pediatric Pulmonary Center.
Great, Angela, thank you.
And that really stood out to me because I'm a family advisor within a group that takes care of the population, or our pediatric population, that has cystic fibrosis.
Mm-hmm.
And as well as they are so vulnerable at the moment because obviously cystic fibrosis primarily affects the lungs, and then you have the fears around COVID-19 on top of that. Mm-hmm. So I have been working very hard with my team over the last couple of months, and they've been, very, on the one hand, really worried to try and keep the children with CF out of the hospitals to try and minimize their risk, but then at the same time trying to continue to make sure that they get their treatments, and we've spent a lot of time connecting with the patients and their parents and their caregivers, and trying to assure them that we're there for them while we don't want them to come to the hospital, but giving them lots of opportunities or new ways to contact us. And then of course, telehealth came into all of that. So that's what immediately struck me when I saw that topic listed, and just sort of the added fears for that very vulnerable population.
Great. Well, thank you for sharing that. I know, Darcel, you were wanting to make a comment.
Yes, I agree. I work at Children's National Hospital in Washington, D.C., and I am both a mother of a child with medical complexity as well as an employee, a patient family coordinator, and a parent advisor on our PFAC. And we recently did a poll amongst our patients and families with regards to just how they may be feeling or concerning about continuing to come to the hospital as we work to recover. And a large portion of the population, especially those who had children who may have had multiple conditions, multiple diagnoses, cardiology diagnosis, respiratory, cancer, et cetera, had an overwhelming concern about how to manage those kind of diagnoses in this time, and how to receive care. Some surgeries may have been put off, which should have been, but what is the time frame that they can wait before they have to come back? And so how do we really juggle managing not just single conditions, but multiple conditions in this time in a way that families feel safe, feel informed, and that we're not putting them at increased risk as we start to open the doors to allow more patients and families to return.
Mm-hmm, mm-hmm. And as I was listening to you, Darcel, there is a lot of complexity, and it really is in some ways around having information and support so that risk can be managed, and the complexity of the risk is so much greater than someone who may not have underlying conditions, may not have the level of complexity that the children that you were describing had. So I really appreciate you sharing that. I know some of you may not be able to join the audio. I know that Lauren mentioned that that her audio wasn't working, but she brings to an important point the issue of health disparities related to children of color and those with intellectual and developmental disabilities hardest, in addition to the medically complex, which Darcel was just talking about, and the whole issue of health rationing. So those are issues that really are beginning to surface. And how do we really invite parents in a safe way to be able to be in the hospital for children with disabilities? So these are all really important issues. Does anyone else want to speak a little more to the current impact of vulnerable populations?
As I look in the computer, Friday's surgery on the 29th.
I'm not sure who's talking. And can you say that again? You're concerned about surgery scheduling? Well, go ahead.
I share, that wasn't me, but I share concerns about medically complex as the parent of a child who's already on a vent, feeding tube, and many other complications. Mm-hmm. And so I share that. And I also, as I work coordinating the Health Information Center here, I have many parents with the same kind of, more or less medically complex illnesses. And I find that I found that there weren't policies or procedures in place in case something like this happened. And so it's a scary place to be when one parent said to me, will they take my vent away from my child? Mm. And is there a policy to protect the children that are already in this very, very non-safe place? And then is there an environment in the hospital for kids like that, where they can be segregated, if you will, in protection in case there are other COVID cases within the hospital. I think those are considerations and concerns of all of us.
So it sounds like being aware of what might be best practice in this situation, and have there been hospitals that have created policies and procedures and put those in place to address those issues might be helpful?
Yes.
Okay, great. And
It's
again,
not, it's
go
not
ahead.
negligent.
This is-
I think we all need to realize and have patience. It's not
Mhm.
that it's negligent at all. It's just that they haven't thought about it, or they haven't involved parents that have those issues to help them think about it. So it's not a criticism. It's just, we got to think about this.
Exactly, exactly. And part of the purpose of this conversation is really to surface what are the concerns and the issues, and what are areas of attention where we need to be spending time on those things to address those areas that are gaps that weren't created intentionally, but who knew, you know, had we, I mean, there might be a few individuals who knew and sounded the alarm, but we weren't all necessarily listening. And so now it's really brought to our attention full scale that there are areas and gaps that we need to address together in partnership with other individuals. I noticed that there has been some conversation around the whole issue of, not only do we have individuals who are medically fragile, but they may have languages other than English that are spoken, and how are we addressing those issues? Are other people either addressing those issues, or have found that that is important, an important consideration for us to find best practices about those?
I'd like to speak to that, Mary.
Okay, Lillian, thank you.
Hi, I'm Lillian Hanning. I'm the Family Centered Care Coordinator for the Pediatric ICU and IMU at Children's Memorial Hermann in Houston, Texas. And we, as far as Spanish and Arabic interpreters, because Houston is very diverse, we have in-person interpreters every day from, I don't know, 7 a.m. until 6 p.m. And then every unit has multiple iPads, or whatever they are, I guess they're iPads, that have the language line.
Mm-hmm.
And in my PICU, for instance, we have 5 iPads for a 30-bed unit. And in the intermediate unit, which has also 30 beds, they have 4 of them. So they're very readily available. We have not found it necessary to have one in every room. But when I am making rounds and meeting families during the day, I always make a point, because most of our non-English speaking people are Spanish speaking. I always make a point to get an in-person interpreter, just because I feel like someone that has come from the bedside recently, 7-8 months ago, I feel like a lot of the anecdotal conversation that you have with a family, your baby has beautiful curly hair, I like your outfit, that's a nice pink shirt, all those little things that we would say as we pass somebody to enhance relationship building, we're missing that with people that do not speak the language that we speak. And so I always have an in-person interpreter with me, and I encourage the parents to call an in-person interpreter or ask the nurse to call one, because they're there till 6 p.m. And interestingly, in my rounding, most of the time the bedside nurse is there, and they are learning that we have in-person interpreters all the time. And if tomorrow I needed to schedule a Swahili interpreter from 9 to noon or whatever, we can do that as long as I give our interpreter services a day in advance. They can bring somebody in to be at the bedside for a block of time, so that we can show this family that, you know, we're going to do our best to make their education about this disease process and what's going on in the hospital a priority. And so I'm kind of proud of that our hospital has done that, and it's still inadequate because only talking to someone that speaks Swahili for a few hours a day, what about the other, 18, 20 hours of the day? It's difficult for them, but it is better. It's better for sure. So that's all I have on that.
Great. Lillian, I noticed that there was a question from Kate as you were talking about having interpreters and live interpreters, and her question was, and you may be able to address this or not, and maybe other people can address this, but has there been a change in the practice on in-person interpretation in anyone's institution due to the need to conserve PPE?
Well, yes, actually, as I am rounding and visiting with families and trying to make them more comfortable in this extremely uncomfortable and weird setting, or my boss has asked if I would conserve the PPE, and so to have people come to the door, or we are not making parents be prisoners in the room, so they are allowed to come out, go get food, come back, that kind of thing. So for the COVID patients especially, I am not going in those rooms, nor is the interpreter. We are asking the parents to come out with a regular mask after they wash up and all that in an effort to conserve. But for those children that are not in isolation or that are just on basic, like if they have MRSA or something that does not require the head to toe gear, if the family needs me, then yes, I absolutely go in, and so does the interpreter. So that is on a case-by-case basis in the children's hospital, and I can say we don't really have a policy. We're just acting accordingly to be as compassionate as we can with these families, because if we can all imagine this, and I don't need to say this to anybody on this call, but this is stressing me out, and I can't imagine having a child in the bed too. And not to mention that, but on the previous poll question, these parents are alone. I mean, I can think of several families that have been in this hospital since January, and they're alone. Their support person is at the house. And, you can just see how they're getting sadder and sadder and sadder. And I just, I'm not hugging people like I otherwise normally would have. When parents burst into tears when I come in because they know that I'm there to be a medical translator for them, and they can't hug me, it's kind of horrible. But we are doing our best, and they know. Every parent says to me, I know that you guys are doing your best, and I understand it. I don't like it emotionally, but I understand it. So it's been kind of an extraordinary experience to go through this at this time, and to interact with these parents during this. Most of our patients are babies, so I'm not talking to the kid. So anyway, did I answer that question? Kind of.
Yes, I think you did. And thanks, Lillian.
You're welcome.
What I also noticed is that there is a bunch of conversation happening on chat related to that some institutions really are using VRI interpretation and not having live interpreters at the bedside. And Karen, you mentioned something that I think is really important for us as we're thinking about ethical and just treatment, which is the issue of, now where did it go? It had to do with being able also to consider the cultural perspective as it relates to trust in institutions, family situations, and work situations. Karen, did you want to share any more about that than you were able to in 2 sentences in the chat? How is your institution addressing that issue?
Sure. We talked about this, Mary, when we were talking about the screening and visitation policies. That some questions came up about what are the screening questions when people come into the hospital with their child. You're asking about their health status, or is anybody in their immediate household been at a high exposure risk? And part of the issue is, are you going to get, what kind of answer are you going to get? Because people know that if you say, someone in my household has been exposed, they're going to be worried that you're not going to let them in the building, and then they're going to be separated from their child. that's all of that stuff is compounded by populations of folks who don't feel safe in a typical big bureaucracy institution, that they don't know how to talk easily to authority figures, or they're worried about whether they're going to be taken because of their insurance or their financial situation. All of those things are go beyond just the, do I understand the words that you're saying, but do I know how to advocate for myself and my child, and do I know how to interact as part of that team? So I think it's just, you want to look at all the different layers and prisms that people are bringing to any interaction. And that's not to say you don't start with language, but you also want to know that just understanding the words is not enough for knowing how people are interpreting what things are happening for them.
Great, thank you, Karen. And I noticed these are so, these nuances are critical to the connection that we need to make with patients and their families, especially as it relates to pediatrics. Kara, I noticed that you were talking a little bit about different culturally responsive forms and methods of communication. Can you speak more about that?
Sure. I think, you know, we already know and knew before this lovely pesky pandemic, whatever you want to call it, that there was, you know, a real gap in linguistically appropriate and culturally responsive communication. But just even, you know, during this chat, people have brought up, you know, the need to communicate, you know, what hospital administrations and practices are doing and their thoughts behind their planning and otherwise. But there seems to be during the pandemic a real chasm of, in general, that's not always being communicated to families, but particularly those who are diverse and underserved. You know, as Karen was just talking about, immigrant families, for example, that may be fearing, you know, from experiences in their own countries and lack of trust with government and other officials, but also fearing ICE and how could this somehow connect into deportation in other ways. And there's just, you know, some communities trust Facebook and use that as their primary source of communication, and others don't. Some have email and others don't. Some use WeChat or WeChat, or I don't even know all the I mean, there's just so many different types, and getting all the communication into the right modes. We can't just live in listservs anymore. That Zoom has really opened us up to other things, Facebook Live, you know, and just how do we get everyone to take advantage of that and make sure, as everyone's pointed out, there's consistent messaging, there's linguistically appropriate messaging, there's culturally responsive messaging. You know, and it's great that there's interpretation services being used, but, you know, I'm hearing that on telehealth, it's not always appropriate or available, or sometimes there aren't telehealth calls because there's no interpreter, because it's just an audio telehealth call. And, you know, there's just a lot of things that we can do, but I think it's a silver lining and hopefully an opportunity of the pandemic as well to really expand what is in our toolbox.
Mm-hmm, mm-hmm. Well, and that really gets at something that you guys listed as a priority in terms of just the percentages, which really gets at, you know, what are the policies and practices in a new normal, that we aren't going to necessarily be going back to the way things were. And so have any of your hospitals begun the process of working, I'm going to kind of combine a couple things that you guys thought were important, involving the family advisors and family advisory councils related to development of policies and practices in the new normal? Have people begun those kinds of proactive conversations even in the midst of the pandemic, which, you know, isn't going to go away in the near future? I'm just curious what might be happening out in the field.
Hi, this is Darcel again from Children's National. I mentioned earlier that we sent out a poll to our patients and families, because one of the things that was important in this organization is that when we start to develop what the new normal is, that we are doing it in conjunction with our patients and families. So this is inclusive of our hospital-wide Patient and Family Advisory Council, as well as our disease and diagnosis specific PACs and our virtual PACs, to see what is important to our families in making these decisions of the new normal. And we will be forming, with the next couple of weeks, subcommittees to handle certain key items that came as high priority. So part of it would be as Karen mentioned, this communication and consistent communication so that families are getting the same consistent messaging throughout, no matter whom they speak to. There were a lot of questions regarding transparency with regards to how many may be in our hospital that are staff and patients and families that are positive, that is information that we can let them know. And then from that, what the kind of procedures would be to make sure that we are having a separation for those that may have been affected or those that are not when they're coming in for hospital stays or patient appointments on the front end. It's just as well as everything from wayfinding, how to know to get best part of the building without having to go through the building, to not enter some high volume areas. And so we are really taking the poll responses in order to really make what this new normal is going to look like.
Great, thanks, Darcel. Linda Starnes, I noticed that you put a resource in the chat related to the Mailman Center for Child Development and the work of developing medical triage guidelines that speak to non-discrimination, which relates to preparing for, policies and practices that really are culturally sensitive and are going to meet the needs of kids and their families. Do you have any more that you want to share about that? I know that you shared the link and everybody has access to it, and we'll be keeping a copy of that in the chat record. But I wanted to give you a chance.
Yeah, sure. Hey, everyone. This is Linda Starnes, and I'm in the Orlando area. And as you'll see in what I put in, I wear a variety of different hats, but I have been a part of the state level conversation on medical triaging and bioethics. And there is a policy that we have developed that is in front of our governor for approvals. It hasn't happened yet, but it's there. And resides at the Florida Bioethics Network. If you would care to Google that and you want to see the policy that's been developed. But along with that, the Mailman Center, which had some of the lead voices on this state conversation, realized that the implicit and explicit biases regarding people with disabilities is still prevalent in our medical circles, and that there needed to be more out there that speaks specifically to that when looking at medical rationing and triage. And so they put together about a 15-minute training for providers. It's very well done. It's free and available, and it's been put out nationally at a variety of websites across the country. But this might be something you want to share at your various places of work as well.
Great, thank you so much.
Yeah, hopefully that will give some nice entree into the conversation about how people with disabilities or family members need to be present on those very bioethics boards at our various health institutions.
Great, thank you for sharing that. Teresa Rogers, I noticed that you were talking about, in response to my question about patients and families being involved, you have a virtual strategy committee and a resumptive and reimagining of services committee. Tell us more about that, if you can. I know some people can't join the audio. So perhaps we'll follow up with Teresa outside of this meeting and see if we can get some more information. Yeah, she just said she can't join the audio. That's unfortunate, Teresa, but we'll do some follow-up with you. So I'm noticing that it's 9:44, and I wanted to explore for just a minute the whole issue of long-term harms to children that came up as something that people were concerned about. Any thoughts that people want to share about that? Are any of your institutions gathering data on that or polling families and about their concerns related to that?
Mary, this is Lillian again. it's on a similar vein. We are in the process of doing a case study on how this COVID has kind of changed things. And we're going to do it on about 8 to 10 families. And some of these families have only been in the hospital for a small bit of time, like, 3 or 4 days or a week. And some of them have been here since before we started this lockdown and are moving through it with us. And so it'll be interesting to see how that goes. And I will keep you updated when we complete the study and submit the paper.
Great. Thank you, Lillian. Anyone else? So I'm going to shift just because of the time frame, not because we don't want to have more conversation about this, and we will, since we have conversations planned in the future. And anything we don't get to today, we will certainly be wrapping back around. But Natasha, if you can go to the next slide. Wanted to really quickly give people a chance to take a look at these particular questions that came in from other members of the PFCC community that were interested in hearing about success, or if family-centered rounds have changed, what's the current trend in visitor policies. If you have anything that you want to share on any of these things, I want to just open up the floor to that. Give you a minute to read through it. I know that we talked a little bit about telehealth already. Any virtual or digital implementations that people found had positive impact? That certainly is an area that probably will be studied after the pandemic.
I have something. This is Marielle Spengler. I'm from Lucille Packard Children's Hospital in Palo Alto. I think I mentioned this a few times ago, but we've been doing virtual rounding with families, with our parent mentors, since we can't enter the hospital. But that's been a unique partnership with our command center nursing leadership when they have had updates to policy. It started out initially in early March of visiting each family, but then we transitioned to doing that by phone. And so they've been in communication with us anytime there is a change in policy as things have shifted, so that families get advanced warning of a change happening.
Great, thanks for sharing that. Because not everybody's been on every conversation. It's always good to be reminded of great practices that are happening.
And this is Kate Mayer from Lucille Packard as well. And what Mariel's group found when they were doing virtual rounding was that families that were going hungry. And so out of that, the foundation had talked to our boss and said, what do families need? And so this food insecurity came up, and out of that, food resource program is starting. And that's led to a lot of partnerships with social work, with child life, with nurse leadership, and just there's a huge group of people working towards this. So they've gotten a grant for 5 months, and they're hoping to create something that's a little more permanent after that's over. It's been
Yes, I would think with the economic downturn that that may become more and more of an issue, the food insecurity, and how we can collaborate with community resources and link people, as well as provide immediate assistance from the organization, is going to be an important thing. Deborah, I know that we've got about 10 minutes left, and I always like to give the chat monitor an opportunity to comment on anything that you've seen that perhaps I've missed, or that you want to call on somebody to elaborate a little more on. Do you have anything you want to add?
I think that there are a number of things that have been raised, specifically how patient and family advisors are used in different situations. And I think that's one thing that we're going to hope to do as we move forward with this series, that no matter what the larger topic is, part of it will be how did patient and family advisors or existing advisory councils, how were they involved in the problem solving and the creating of new strategies all the way to the new normal. I also wanted to mention family presence was one topic that we haven't specifically addressed. But very shortly, there is actually going to be a new set of guidelines issued about family presence, specifically during COVID-19, but beyond that, that will provide really workable general guidelines across a variety of settings. And it was created by a large collaborative. So I think the usefulness of the document in saying that many organizations came together to address this really, really important issue that has created some harm already.
Mm-hmm. Mm-hmm. Are any of the organizations on the line or advisors noticing any shifting in family presence policies over time?
Mary, I can't speak right now to pediatrics, but some dramatic shifts right now. The biggest one, and it's been reported on in the media, is that New York City has a pilot program now with 16, I'm sorry, it's not just New York City, it's New York State, but a pilot program with 16 different hospitals, 9 of which are in the city itself, where of course the number of COVID cases was so astronomically high, which suggests, I think, some hope that if New York City and New York State can start piloting and start moving away from the incredibly strict guidelines that were instituted at the very beginning, that again, that would be something that other people could say, well, if New York City can start doing this, then perhaps we can too.
Mm-hmm. Mm-hmm. Yeah, I think
this is Jen Faulkner from, oh, sorry.
No, go ahead.
Oh, I was going to say, this is Jen Faulkner from Seattle Children's Hospital, and recently they have allowed inpatient families to have 2 caregivers at the bedside again. For the majority of the time, we were requiring families to have only 1 caregiver at the bedside, except in certain extenuating circumstances. And that has, so we have just loosened that within the last 2 weeks. And I think there's some more talk now about what's the phased approach to going back to where even, you can have 2 caregivers in clinic and thinking through that process. So we're seeing a little bit of change back towards those regular visitation policies.
Oh, that's great. Great. And it looks like there have been some more chats about some shifts that others have been making. So that's really great. In the interest of time and keeping us honest to only tying you up for 60 minutes, if we can go to the next slide, Natasha. we just want to remind you that the upcoming webinar that's going to be focusing on the most vulnerable children that Deborah is coordinating will be happening on June 25th. And Deborah has just put in the chat the link to registering for that free webinar. Is around how do we ensure that children with special healthcare needs receive the care, health and otherwise, that they need in the time of the pandemic, which came up as a really high priority in this conversation. So I think that that'll be a very timely webinar to have. So we encourage any of you that can to share the information with others and sign up yourselves if you would like to participate. If we can go to the next slide, please, Natasha. So we're kind of wrapping up. For those of you that might not be aware, we do have our website, a whole special section for PFCC and COVID-19, and it shares helpful resources, and the one that the collaborative family presence policy recommendations that Deborah was just talking about will be connected to this particular site as well as other sites, because so many organizations have been involved, but we want you to be aware of that. And the other thing is many of you provided some examples and shared some resources in the chat, but as you continue to evolve and develop your best practices, your policies, we really encourage you to share those resources with us so we can share them more broadly. If we can go to the next slide. And to that end, we wanted to let you know that we are doing a survey for tracking the impact of COVID-19 on PFCC and across all settings. But we encourage you to, if you haven't already, complete the survey. You can do it at a unit level, you can do it at an organizational level. People who are patient and family advisors, parent advisors, can, if they're aware of what their institution is doing, and many of you I know are, you can also fill out the survey. And so the other nice thing about this survey is that you can then click and see the results, not necessarily from that day, but we're collaborating with the University of California in San Francisco, and they're kind of aggregating the data and putting information out about what's happening across the nation in a variety of settings. So we wanted you to be aware of that. That's something new that just hit the website last week. So next slide, please. For those of you that aren't PFCC members, or if you know of other people in your advisory councils or in your organization that want to join the learning community for ongoing informal discussions, and there were a number over the weekend that are useful, people sharing different examples, we encourage you to do that as well. The next slide, please, Natasha. So we will post the recording of today's conversation, the chat record, and the slides, and you will also get that in an email in about a week from Natasha. We encourage you to continue the conversation on the learning community and connect with other people who are working to advance patient and family-centered care despite the obstacles that the pandemic has challenged us with. However, I was talking with somebody who was saying that, you know, there are some silver linings, and we want to make sure that whatever silver linings have been discovered during this pandemic, that we integrate those into ongoing new normal practices and policies, as well as address the gaps that have been uncovered during this time. So we encourage you to be part of that community. Next slide. We wanted to let people know that we're going to have a big announcement about our international conference on May 28th, which is 2 days from now. Watch for it on our website and in Pinwheel Pages. So if you get Pinwheel Pages, you'll get some information about that. It is exciting news, and I think you're going to be very interested to hear about how we're going to approach our 9th International Conference on Patient and Family-Centered Care. We go to the last slide. Right on time. We want to thank you for joining us, and as Deborah has done, she's indicated and put in the link to our Survey Monkey, so you can tell us about your experience today, suggest other things that we might wanting to be focused on, and feel free to contact either myself or Deborah about today's conversation, and Deborah in particular about this very important Lucille Packard project that we're going to be working on for the next 6 months. So thank you very much for joining us, and we will hopefully talk with you and learn from you in the future. Take care.